Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jacqueline Meredith. This episode features content from an educational symposium titled Modern Approaches to CMV Prevention in Solid Organ Transplant Recipients, featuring Dr. Hannah Imlay, Associate Professor of Medicine, part of the Department of Internal Medicine, Division of Infectious Diseases at the University of Utah in Salt Lake City, Utah. In this episode, she discusses CMV prevention strategies in solid organ transplant recipients. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what she has to say about this topic.
I'm going to talk about modernizing preventive approaches, which is a key part of CMV management in your organ transplant program. And really, I'm going to focus on three aspects guided by recent data of preventive approaches, and then follow up with a discussion of viral loads and semi-recent updates in viral load information. So to start off with, let's talk about the major types of preventive strategies. These are outlined here. The first is prophylaxis. This is fairly straightforward. You give your transplant recipient an antiviral for a fixed period of time, typically 3 to 6 months, and you give it every day at a lower dose than what you use for treatment until you're done with prophylaxis. And the goal of prophylaxis is to suppress viral replication for the period of time when patients are the most immunosuppressed, the period of time directly following transplant. The second is preemptive therapy, and this is testing-based therapy. Each of those circles represent a test. It's typically done weekly. And if the circle is open, it means the test is negative. There is no viral load detected. If it is a closed circle, that implies a positive viral load, either any detection or a detection above a certain threshold. And those arrows represent treatment. So giving antiviral at a treatment dose until the viral load again goes to zero, and then continuing testing until the end of the preemptive therapy period. The third is the hybrid model, which many centers have adopted. I'm actually not going to talk so much about the hybrid model for the rest of this discussion, because there's not a lot of data directly addressing the hybrid model, but it's essentially a period of prophylaxis, then followed by a period of PET. So ideally trying to get the best of both worlds. So these are the 2018 and 2019 consensus guidelines. There are two guidelines. I smushed them together. My colleagues are each authors on one of them. And really, they're fairly consistent and have recommendations for how long to pursue prophylaxis or PET based on two of the most important variables for the risk of CMV disease and severe CMV. And that includes the serostatus, so either D plus R minus or R plus, and the type of transplant. So you can see the organs there on the left. And you can see a couple things here. First off, for our more heavily immunosuppressed organ transplants, generally prophylaxis is preferred and they're not recommended alternative strategies for PET. But for kidney, liver, and heart, PET is listed as an alternative. And the typical durations, as you can see here, are 3 to 6 months. So comparing the pros and cons of different CMV prevention strategies. On the left here, prophylaxis therapy. The clear downside of this is the risk for drug toxicity, and every patient receives this antiviral, so every patient is at risk for drug toxicity for the prophylaxis period. Because of that, it can also be expensive. And prophylaxis is commonly associated with late onset disease. For the 3-month period after prophylaxis ends, a very high risk of CMV replication and CMV disease, especially in our D plus R minus patients. Post-prophylaxis CMV disease is really an issue for those patients. However, the potential benefit is that it may prevent the indirect effects of CMV replication. So these indirect things like opportunistic infections or graft rejection associated with CMV DNA detection, at least for the period of prophylaxis. And this was the historically common approach for organ transplant recipients. Preemptive therapy, by contrast, one of the benefits is that your immune system gets a little bit of exposure, a little taste of CMV, with the goal of responding rapidly, giving therapy prior to the replication getting out of control and causing CMV disease. As a result, your program must be able to respond quickly to start antiviral therapy. And logistical concerns is a major limitation, at least theoretically, of initiating PET as your sort of preventive strategy. This is historically common for stem cell transplant recipients because of the drug toxicity issue. We will not really talk about stem cell transplant recipients, though, for most of the rest of this. And this brings us to our first study. This is a recent study that was published in 2020 that was a randomized double-blind placebo-controlled trial of 205 D plus or minus liver transplant recipients comparing a PET strategy versus an antiviral prophylaxis strategy for 100 days, or about 3 months. And you can see that about 15% received thymoglobulin for induction. The major endpoint here was the risk of CMV disease. And so you can see the cumulative incidence curves here on the right. And you can see that there were lower rates of CMV disease in the PET arm, as opposed to the antiviral prophylaxis arm at 1 year, 9% versus 19%. And this difference was driven by less late onset disease in the PET. Other details about this study, the other major outcomes that were evaluated are things that are associated with some of these indirect effects. So the risk of allograft rejection, graft loss, opportunistic infections, and all-cause mortality, which were all very similar within groups at 1 year. And then lastly, neutropenia, which was also quite similar, which is a common complication of valganciclovir. You can also see that in the PET arm, the vast majority of patients developed DNAemia, and the majority developed it quickly within a month. And then half of them had recurrent anemia as well. However, among the patients who underwent testing for metrics of CMV-specific immunity, which were neutralizing antibodies or T-cell analysis, you can see this is the results at the 3-month window. So right after the two groups would have finished either prophylaxis or PET. And you can see that those who were in the PET arm had higher metrics of CMV-specific immunity, both measured by CD4 and CD8 cytokine response in response to CMV-specific antigens. And so the kind of takeaway here was that viral suppression with antiviral prophylaxis, as opposed to controlled viral replication as a strategy associated with suboptimal CMV immunity and the higher impairment in the development of T-cell responses after that prophylaxis window. So we're going to move on to our second aspect of prevention that we'll discuss. And this is really a focus on antivirals, and specifically antivirals used for prophylaxis. There are 3 major antivirals that could be considered for this purpose. Valganciclovir, which has been commonly historically used, buscarnet and letermovir. Valganciclovir carries an FDA approval for CMV prevention for kidney, heart, or lung transplant patients, and again has been most commonly used. Buscarnet is could be used off-label, but has significant toxicity limitations, and so is not a common drug that we pick for CMV prevention. And then lastly, letermovir, the newest kid on the block. This was approved for CMV prevention in R+ stem cell transplant recipients in 2017. And I'm going to talk about the second indication, D plus R minus kidney transplant recipients, which occurred just this year. This is breaking news. Letermovir has not really been associated with cytotoxicity and renal toxicity in either of these randomized controlled trials. However, there have been prior reports of CMV treatment failures and letermovir resistance when used for prophylaxis. And when the trial was planned, this was something that we were all looking out for. Will there be breakthrough viremia or disease? So this was done as a randomized placebo-controlled phase 3 trial of about 600 D plus or minus kidney patients who were given antiviral prophylaxis for 200 days or 6 months. And then CMV disease, again, was the major endpoint that was measured at about a year and determined that letermovir was non-inferior to valganciclovir in preventing CMV disease through week 52 or 1 year. And you can see here on the right, very similar rates of CMV disease. In addition, detection of CMV in either arm were not substantially different. You can see that numerically it was higher in the valganciclovir arm, and many of these cases were associated with needing to prematurely stop valganciclovir and then having subsequent CMV replication. And the occurrence of resistance-associated substitutions also was not higher in the letermovir arm. So some of these concerns were allayed despite these reports of breakthrough CMV. You can see down here that kind of very importantly focusing on side effects, a lot of the side effect profile favors letermovir, and that's not surprising. We know that valganciclovir is a frustrating cause of cytotoxicity. And so leukopenia or neutropenia measured different ways were all much less common in the letermovir group. And so the major takeaway here is letermovir was non-inferior to valganciclovir for CMV disease prevention, but it had an improved safety profile. So the last thing we'll discuss is CMV cell-mediated immunity monitoring, which I will call CMI monitoring. I will talk about it a little bit, as will my colleague, in the next presentation. And basically, there are several assays that attempt to measure specific T cell responses in the host to specific CMV antigens. And this includes stimulation of T cells using CMV antigens or other peptides, and then the measurement of the cytokine response. If someone has a high response, that implies CMV-specific CD4 and or CD8 T cell immunity, which ideally should imply a lower risk of severe CMV outcomes or CMV disease. If there's a low result or a negative result, that implies the lack of CMV-specific CD4 and or CD8 T cell immunity, and therefore confers a higher risk of CMV reactivation and progression. There are a limited number of assays available, so that they're all designed slightly differently, but generally follow that same formula. And one major limitation, at least at my center, is that the majority of the assays for which there are substantial amounts of data are not accessible in the United States. But the potential uses of these assays, including determining the duration of primary prophylaxis, that's what I'll be talking about, assessing the need for or duration of secondary prophylaxis, you'll hear about that next, or identifying the duration of CMV monitoring. This is an attempt to summarize the existing data for using CMI monitoring to tailor primary prophylaxis duration. So that the studies that use the results of these tests to start or elongate or stop prophylaxis. There's kind of two major study designs, and these are divided by the enrolled patients that are very highly immunosuppressed, so this top kind of group of studies, which are heart and lung recipients, or maybe less immunosuppressed in general, which are kidney and liver recipients. Those are the two studies that I'll summarize on the bottom. In the first kind of major study design is the question of extension of duration of primary prophylaxis. So in these studies, which includes one randomized control trial and two non-randomized comparative studies in heart and lung recipients, patients were typically given 5 months of prophylaxis. But if they had negative CMI testing, that would be extended up until 11 months of prophylaxis. And the major finding in these three studies were that the arms who received CMI monitoring had a longer prophylaxis duration, which was serostatus dependent. The D plus or minus needed longer than the R plus to have a positive CMI assay result. But a lower burden of CMV replication was observed in the arm who received CMI monitoring versus not. In kind of the other major study design, these were questions of shortening prophylaxis. So patients would actually receive regular CMI monitoring up to a duration of 3 months of prophylaxis. So if they had a positive CMI before 3 months, their prophylaxis was stopped early. And if they had a negative CMI before 3 months, they would continue that standard prophylaxis duration to 3 months. These were open label randomized trials in kidney and liver recipients. And the major finding between these two studies were that the arms who received CMI monitoring had a shorter prophylaxis duration, which makes sense, but a similar burden of CMV replication was observed in both arms. This was also very serostatus dependent, so the D plus or minus patients generally needed, the majority of them needed about 3 months of prophylaxis and did not actually stop prophylaxis much sooner than 3 months. So the take-home points from these studies are that in patients with positive CMI assays, there has been observed less subsequent CMV replication or disease. Among patients who are CMV R plus at the time of transplant, there seems to be a low rate of CMV disease regardless of the approach, CMI guided versus not. And among patients who have CMV D plus or minus serostatus, there's poor test performance for a couple of reasons. First, and most importantly, very few patients who are D plus or minus at their transplant have CMI positivity at transplant, and very few develop CMI while they're being given antiviral prophylaxis. And among those who develop CMI, CMV replication is still often observed. And this reliably identifies the serostatus as a major factor associated with subsequent CMV, regardless of the study arm. And then the last major limitation from these set of studies is that the study's assays are not widely available in the United States or commercially available. So my recommendations, based on the recent data on preventive strategies. For kidney transplants, for programs using universal prophylaxis, considering the switch to letermovir as a programmatic choice. Cost and logistics is always the question, and is this affordable for most patients versus valganciclovir? For a liver transplant program, consideration of developing a PET program. I think the major barrier here are logistics, but to be honest, many centers who are doing hybrid models where they're doing PET may be doing the same work just later in the time frame after transplant. The remaining questions I have: should we reconsider PET for other organ groups, given this idea that immunity may be very helpful in preventing later onset CMV? Studies are ongoing still to determine the precise role of CMV-CMI monitoring for primary prophylaxis. And then the last question is, what about use of viral loads? So we know and have already discussed that the presence of DNA-emia is associated with indirect morbidity. And this includes organ rejection, opportunistic infections, potentially mortality. And that high-level CMV replication and genetics are associated with the risk of CMV disease. And these are the two major reasons why we want to prevent CMV in the first place. However, we've mostly focused on D+ or minus. Those are the highest risk serostatus. But when you think about R+ and using a PET program for R+, this may require establishing an absolute threshold beyond which asymptomatic DNA-emia would be treated. For this, quantitative molecular viral load testing is recommended, and an international standard was created in 2010 to help standardize. There are several limitations of quantitative nucleic acid testing. We know that CMV viral load assays vary, and they vary on a number of variables, including the specimen type, so whole blood versus plasma, the gene target, amplicon size, and DNA extraction techniques, which means that the answer you get may be very different based on which assay you're using. An international standard was developed, as I mentioned, in 2010, which has reduced the variability, but it persists to a clinically important degree. And as a result, we're really unable to directly compare viral loads across labs or assays. And this limits the potential for an evidence-based viral load at one center to then be used at a different center exactly as they did it at the first center. And so the recommendation is to monitor using the same assay and establish assay-specific thresholds for PET for your own PET program. So the future of prevention approaches, as I'm predicting now, may be characterized by more focus on CMV immune recognition that may or may not include vaccines, or immune monitoring, further data in that arena. The ongoing debate on PET versus prophylaxis, and the use of letermovir for prophylaxis on a programmatic level for high-risk kidney transplant recipients. Key take-home points from this section: PET and antiviral prophylaxis are CMV prevention strategies used during high-risk periods directly after transplant. Strategies that increase CMV-specific immunity are associated with a lower risk of late CMV disease. Letermovir and valganciclovir are good options for antiviral prophylaxis in high-risk kidney recipients. And since CMV quantitative nucleic acid testing varies, it is recommended to use the same assay when monitoring changes in viral loads.
Thank you very much to Dr. Imlay, and thank you to our listeners for joining in. To hear more episodes from this session on CMV, see the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.